Welcome to the second session of this new weekly series of webinars every Thursday at 5 p.m. to 6:30 p.m. organized by our group here at the University of Miami. This is session 2. I am Jacques Morcos, professor and co-chair of the Department of Neurosurgery and Otolaryngology and director of cerebrovascular and skull-based surgery at the University of Miami and at Jackson Memorial Hospital. It's also a great pleasure that my co-directors are also here. Carolina Benjamin, assistant professor of the Department of Neurosurgery, director of the Keynes Lab, specializing in brain tumors and skull-based surgery, and also at Jackson North Hospital. Michael Ivan, assistant professor, Department of Neurosurgery, director of research at the BTI Tumor Initiative, specializing in brain tumor, skull-based, and epilepsy surgery at the University of Miami. Robert Stark, assistant professor and co-director of endovascular neurosurgery and director of endovascular research. And lastly, Eric Peterson, associate professor, Department of Neurosurgery and director of endovascular neurosurgery. Well, as you know, we are here in Miami, Florida. Those of you who have not visited, of course, are very encouraged to come and visit. This is our medical complex, the beautiful city we live in. This is on the left, University of Miami Hospital. On the bottom right is Jackson Memorial Hospital. We're a large, high volume tertiary referral center, regionally as well as nationally, and get referred lots of cerebrovascular skull-based cases, of course, among other neurosurgical disciplines as well, clearly with a great commitment for clinical research and educational missions. We are, regarding cerebrovascular program, 3 open vascular surgeons. One of us is a pure open and 2 are duly trained. We have 1 endovascular neurologist, 8 stroke neurologists. Our skull-based surgery program is just too large to go over in detail, but it's a plethora of wonderful multi-specialists in all the disciplines that you would expect at a large tertiary center. We're very proud of our weekly gathering in skull-base every Tuesday evening among all those specialists in a meeting we call the MOBS, multi-specialists of the base of the skull, to discuss very complex things. We have a wonderful cadaveric lab that Carolina Benjamin is directing for, of course, our educational needs in the lab. I will not continue without saying many, many thanks for the following people who made this series of webinars possible. Ingrid Menendez, Administrative Director of Education Program, Residency Fellowships and Medical Education. Roberto Suazo, our extremely talented graphic design project manager. Cristina Sotolongo, Executive Director of Communication, and Ignacio Escalona, who is video production specialist and is currently running this session and the weekly sessions. How can you connect with us if you're interested in our educational activities? Probably the most useful link is what's at the top, which is the link to our website, and it has on it the series of lectures that we are offering. You will see there are some not only on Thursdays, but ones on Wednesday as well that Mike Ivan is running, and I will show you what that is about in a second. You need to go to that website to register for any of the sessions or to view recorded past Zoomposiums through our YouTube channel and to see what else is in store for you. Or you can email various people. You can see the emails there. You can certainly email me or contact me by Twitter or contact the departmental Instagram or the departmental Twitter. This is what's in store for you if you're going to stick with us over the coming many weeks to come, at least for the Thursday sessions. You will see all this on the website at that link I mentioned earlier. It is here at the top, but these are weekly Thursday confirmed speakers and panelists. You can see we're going well into September 10, and I am currently working on sessions after September 10. I'd like to put a great plug-in for the Wednesday Miami Global Brain Tumor Symposiums that Mike Ivan has started already 3 weeks ago. And please come to next week, next Wednesday, June 3rd, presentation by Bill Caldwell on management of paracentral skull-base meningiomas. Co-directors are Rick Komotar and myself. And again, a teaser for next Thursday, this symposium next Thursday. You will notice it alternates between vascular and skull-based topics. Next Thursday is Louis Borba on neuroanatomy and microsurgery of jugular foramen, Chandra Sen on neuroanatomy, microsurgery of the craniovertebral junction. And you can read the names of the wonderful panelists, Naja El Abadi from Morocco, Linda B from the Brigham in Boston, Frank Su from California, Walter Jean from GW, Claudio Jampolsky from Argentina. Housekeeping instructions for tonight, in case you're new to those sessions. This is only our second one. Please use the Q&A box to send your questions. The co-directors and panelists will help in selecting them for discussion. We are not offering CMEs yet. You will get a confirmation email in a few days documenting your participation. And if you like these sessions, please share the links and programs with your colleagues. The panelists tonight, I'm very happy that they joined us. They are experts in their own rights. I will start by introducing Niraf Patel, Assistant Professor of Neurosurgery at the Brigham and Women, Harvard Medical School in Boston. Martin Samis, thank you for being, it's quite a late hour for him in the Czech Republic. He's a chairman and head of the Masaryk Hospital Department of Neurosurgery. Amal AbouHamden, all the way from Adelaide, Australia, Associate Professor specializing in both pediatric and cerebrovascular surgery. And Francisco, known to his friends as Kiko, Gonzalez-Llanos, a spectacular cerebrovascular and skull-based surgeon in Toledo, Spain, at Hospital Virgen de la Salud. Thank you for being panelists. So now I will have the pleasure of introducing our two speakers for the night. First, Fady Charbel, Professor and Head, Richard L. and Gertrude W. Frowen Professor, Chief of Neurovascular Section, the University of Illinois College of Medicine in Chicago, Illinois. Fady is of Lebanese descent from the town of Zahle. He is a microsurgical master. He is an original and a deep thinker, often enigmatic. He's a technical innovator. Among his contributions are the flow probe, the NOVA technique, and many others. He is an entrepreneur. He has a temperament of equanimity. He has relentless drive. He is a leader, a mentor, somebody who knows that a tide needs to lift all boats. He's a true gentleman, and I think that's one of his favorite movies, The Last Emperor. And I think he loves this quote because he says what he means and he means what he says. That's Peter O'Toole in that movie. And what do I share with him? Well, we share, among many other things probably, the Lebanese roots. Our second speaker is Michael Lawton, President and CEO, Professor and Chair of Neurosurgery, Chief of Neurovascular Surgery at the BNI in Phoenix, Arizona. You will see that these two speakers tonight have many traits in common. And on purpose, I actually chose very similar words to describe them. Now, he is not of Lebanese descent. He is of the Midwest. He is unbelievably a microsurgical, wonderful master. He is an original, a deep thinker, also often enigmatic. He is an absolute wonderful technical innovator in creating micro instruments, techniques, approaches. He, like Fady, has a temperament of tremendous equanimity. He has a relentless drive. He is obsessed with self-improvement and a little bit the number 7, as you will see from his many books. But he is obsessed with technique, improvement, teaching. He is a fantastic communicator of technical subtleties. Perhaps it dates back to his college years where he majored in engineering, and that shows very well in his exact thinking. And what do I share with him? Well, we have a common background at the BNI and our time with Spätzle. So that ends my introduction, and now I thank everybody for joining, and I will invite Fady Charbel to share his screen and start his presentation. And make sure you're muted, Fady. Unmute yourself.
All right, here we go. Jacques, too kind of an introduction. I will reciprocate very poorly, but only stating in public what you know privately, which is the great admiration and affection I have for you and for the work that you do. You are indeed blessed with all the skills that you've enumerated kindly on us, but more so with this ineffable quality of charisma and genuine good nature. No wonder you have such a fantastic team with you here today and gravitating towards you like they've gravitated over the years. So congratulations to the Miami team for putting together this symposium. It is the direction of the future. You're showing us what to do. And I know our residents are watching and many around the world are watching. And bravo, Jacques and team for doing this. I'll start by my disclosures. I'm a consultant for Transonic, the flow probe, and I have no financial interest in the Nova vessel technology. You know, early on in my career, I think I was a senior resident in neurosurgery. I came across this quote, blood goes where it is needed, attributed to John Hunter. Of course, John Hunter is the famed Scottish surgeon, one of the most distinguished scientists of surgeons to his days. He was a careful observer of the anatomy, of physiology, and of the scientific method in medicine. And he was a teacher of Jenner, for example, the inventor of the vaccine. So I remember looking at this in the library during my residency, and I was struck by the apparent self-evident nature of this statement, and by its promise to help elucidate many of the mysteries surrounding the outcomes of bypass surgery, because then, as now, many mysteries existed and still do. So now, of course, this quote may be apocryphal. We don't know for sure if it's even true. But even if it's correctly attributed to Hunter, it may not even be accurate. I thought that I'll structure my talk over the next 25 minutes or so to examine this quote of Hunter in the context of the topic assigned to me, which is bypass for cerebral ischemia. And as I will meander through the elements outlined here, I will try to weave a narrative. And my promise to you is if you go through it with me, that by the end of this time, these 25 minutes or so, what I can promise is you would be exposed to a lot of ideas, some of which you already know, you already apply, and that you've already incorporated in your own repertoire of medical surgical practice. But even if not, if you do so, and as we meander this, I believe that for those so inclined, they will become better bypass surgeons. And not only conceptually, but also a better technical surgeon as well. And before I start, I'd like to acknowledge our wonderful fellow this year, Dr. C, who came to us from Niraf's program from the East Coast, from the Brigham. He is this year's Sam and Laurice Hashem Cerebrovascular Fellow. You know, we've been always blown away by the fellows we got. Alfred, just like so many others, but Alfred stands alone in his drive in his attitude, in his enthusiasm, his abilities, of course, but also his conscientiousness and his how he applies himself to the very task that's given to him, even implied without any external motivation. A truly remarkable individual who will miss, but who is destined, I'm sure, to have a fantastic career back east again. So here's where I am right now. I'm on the 4th floor of this building, somewhere here. The Neuropsychiatric Institute, the first of its kind in the US. It was the second modeled after the Montreal Neurological Institute, except it looks like the brain. It was built to look like the brain, with the two hemispheres, the right and left hemispheres connected by the corpus callosum. And it opened at the end of 1941, a little bit before, 2 days actually after Pearl Harbor. It's part of a very large university complex. I love it. It's a true university with many schools that you see the campus here, large campus, and most importantly, the School of Engineering. And I've enjoyed my relationship uninterrupted with the School of Engineering for all the years I've been here. It's been very productive and very relevant to the development of my thinking and of implements to help me test and improve my way of doing things. So out of this work came some of the technologies that Jacques mentioned, the flow measurement tools, whether intraoperatively or perioperatively, and that has been instrumental in helping answer this question. Blood goes where it's needed. Well, does it really? And if it does, why does it? Or does it not? And so forth. So this important question, does blood flow where it's needing? The question is why? If we're performing a procedure to alter blood flow, a bypass in this case, why do we do it? I mean, why do we do this bypass? Of course, we know it's a cool surgery. We know it's a challenging surgery. It's beautiful. But why do we really do it? Many ways to look at that, of course. But conceptually, I believe, and many do share this realization, that any time we perform a procedure such as a bypass, we're doing it for one or two reasons. We're either doing it on the patient who's ischemic, who has an underlying deficit, a pre-existing deficit of flow. And in that case, we endeavor to perform a flow augmentation. And as the result, it will be a net increase of flow because of our surgery. And that's what we'll focus on, what I'll focus on today. And the other category is flow replacement or flow preservation. And this is in the context of a procedure where, as a result of our intervention to cure the problem, such as an aneurysm, rarely a tumor or trauma, but in that process, we create a deficit which we then would need to correct with a flow replacement or flow preservation bypass. And when add to that, then in fact, anytime a microneedle is placed into a vessel, it's done for one of those two reasons, conceptually, and that's it. So having said that, we talked about the flow, and in flow augmentation bypass, which is the topic for ischemia, what is going to be the most important determinant of flow in vivo? And I bring up, of course, the Poiseuille equation, which comes to mind whenever this question is asked. Blood flows where it's needed. Well, why? What drives the flow from point A to point B? Is it the radius? This is the most common answer. I certainly thought so for the longest time. It makes sense intuitively. The radius is to the power of 4, so it directly affects the flow tremendously. But I will submit to your consideration, and I'll show you that in fact the radius is not very important in vivo in the context of what we do. So it's not the radius. So what is it? Is it the length of the vessel? Yeah, the length of the vessel is a factor. Of course, if you look at vessels that are smaller than 2 millimeters, large vessels, it's not a factor. But in shorter than 2 millimeters, if you're narrower than 2 millimeters, if you shorten a vessel, you get more flow, no doubt about it. If you change the rheology, you decrease viscosity. We all know hemodilution works. But the answer to what is the most important determinant of flow, why does blood flow where it is needed from A to B, is the pressure gradient. That is the most important thing. No gradient, no flow. All right, so we've talked about that. How do we measure that? How do we confirm what we're talking about? We have to measure flow. How do we do it quantitatively? Two ways. Either perioperatively with a flow probe that actually measures flow, not velocity. And that is important because velocity changes depending on the diameter. It can increase if the diameter becomes narrower, and that can be misleading. And angiographic patency, now we know, does not correlate with flow. An angiogram will inform us on the fact that there is dye going from point A to point B, but not necessarily the quantity of flow. The pulse certainly does not correlate with flow, can be misleading to the detriment of many of us who relied on that for a long time. And as a result, now we have to be very careful when we see a bypass with a bounding pulse that usually reflects as a reflection of a waveform and an obstruction. This is the perioperative Vassal Nova software, which provides flow quantitatively in the vessels, non-invasively, of course, because it's non-contrast, and allow us then to establish a baseline and to assess serially over time, after surgery or after intervention, the status of the patient, or not, even without intervention. So here's our protocol at UIC for perioperative evaluation of patients with ischemia. It's all MR-based. We start with the NOVA, which is excellent at determining flow in the large conducting vessels. We do it at baseline, as you see here, this patient with carotid occlusion, where you have a reduced flow in these areas with no reserve and even steal in certain territories. So that's the NOVA, with and without a challenge with Diamox. And then we perform a bold global reserve after CO2 challenge to look at the perfusion of the brain with that stressor. And then we complement that with a functional MRI that looks at the regional reserve. And you can see here this patient has congruent deficits in all three tests in the right hemisphere, which together with symptomatology that would be refractive to medical management would make him or her candidate for flow augmentation bypass. All right, what is the cut flow? The cut flow is simply that, meaning you take a vessel, small vessel, don't cut the carotid, but a small vessel, which is the STA, the workhorse of much of what we do, and you cut it. And we've talked about the pressure gradient. Once this vessel is cut, the distal end has no resistance. It's flowing freely, and that will provide us the maximal carrying capacity of this vessel. It's an extremely useful indicator. And what you can see once you start to measure the cut flow of the STA is that the STA is not necessarily low flow as it could be, or high flow as it could be, or a 68 cc's of flow as it is on average. The flow is the STA, in the STA, in a particular STA, is what it is once you measure it. That's the flow in that STA. So I'll show you how this can be relevant. Here's a patient with a flow, undergoing flow augmentation bypass, beautiful STA, but the flow, the cut flow is only 9 cc's, which prompts us to, at this moment, immediately, before going any further in the surgery, examine why that is. And why is that in this case? Because there was a vein that was coagulated crossing the STA, which was not cut. I went ahead and cut that, checked the cut flow again, and it quintupled. So instantly, we averted a problem by checking the STA and informed us that this STA is as good as we thought it would be based on its diameter, but not based on the actual flow at surgery. So very, very useful thing. It is the beginning of any surgery that involves an STA or an occipital artery using the cut flow. Once the cut flow is done, it is extremely useful then to compare it to the bypass flow. And if you divide the bypass flow, by the cut flow, you get an index, for example. If the cut flow is 100 cc, you perform the bypass, and the flow in the bypass is also 100 cc's. Well, then this is an immediate composite number, an index that says instantaneously that everything went as anticipated for whatever reason. Conversely, if a bypass flow is much different from the cut flow, this will prompt us to seriously think about why that happened. And there are many reasons for that. One of the reasons is that a low cut flow index is associated with a very high chance of a failing bypass. So 83% of bypasses long-term that have good cut flow index greater than 50% are patent, whereas less than 46% of bypasses with a low cut flow index are patent long-term. Very, very interesting proposition. And we looked at that in 2005. We looked at it again now with more than almost 300 patients, same results. And you look at the difference in patency, and this is particularly true in flow augmentation bypass. It is less true in flow replacement bypass. I will not talk about flow replacement bypass because Michael will. However, if in the questions later you want to know why or muse about why that is, I'll be happy to expand. So why does the bypass fail? Well, John Hunter said blood goes where it is needed. Why does it not go sometimes from A to B? Examining the flow and analyzing the index, we can divide those reasons for bypass failures into two main categories. The type 1 problem is that a poor indication, and the 2 is a technical problem. The most technical issue is anastomosis, but in bypasses for moya moya, the 2C is the most common problem, and I will explain. So let's start with type 1. What is type 1? Type 1 is a bypass that fails because there's no demand. So but does not go because it is not needed. So that's the corollary of thing. Here's a graft. Here's a graft that was contemplated to the SCA for this patient who had a bilateral vertebral occlusion. This was the era before NOVA, before the ability to measure flow in vessels before MR, and we were not able to determine whether or not this patient truly needed it. He has a large PCOM. And here's the flow, here are the flow recordings at surgery. 3 things I would like you to note. First, in red is the continuous recording of the superficial temporal artery flow throughout the case. At baseline in the scalp, with the artery still flowing against high resistance, the flow in the STA always is very low, always less than 10 cc's. However, here's what happens when you cut it. The same vessel goes from about 3-4 cc's to about 67-68 cc's. What happened? The cut flow eliminated the resistance, the delta P expanded significantly, and now the flow is a function of the true capacity of this vessel. The diameter did not change 1 iota, and you can see what I meant when I said that in vivo, the driver of flow is most importantly the pressure gradient, not the diameter. Here's the same vessel that's clamped again. So that's point 1. Point 2, flow augmentation bypass was the intent to the SCA. Here's before the bypass, and here's after the bypass. Was there any increase in the flow in that superficial superior cerebellar artery? Of course, none. So there was none that occurred. And had we not measured the flow, we would not know that. And why is that? Well, because this patient did not need it. The blood did not flow because it was needed. That patient had a very large PCOM. And the third point, look at the index. This STA, which could provide up to 65 cc's, is only providing maybe 6 cc's. So that's an index of 10%. Type 1 problem. This problem should not be seen anymore in bypasses for flow augmentation nowadays, because we ought to be able to preoperatively, by measuring flow and the hemodynamics of the patient, know for sure whether the patient needs flow augmentation or not. So it'd be a tragedy to find that problem nowadays for flow augmentation bypass type 1. However, it is very common in bypasses for flow replacement, where the demand on the bypass will only occur once the deficit is produced. And there's many ways to handle that, but that's not the subject of my talk. Only to say that think of the surgery as a flow replacement bypass that aims to replace the deficit, no more and no less. But in ischemia then, the most common bypass for ischemia nowadays is Moya-Moya, and in Moya-Moya, 2C is the problem. What is 2C? 2C is a bypass like this one, where it looks great on angio, nice donor, nice recipient, but it goes nowhere. And the index is only 27%. Why is that in Moya-Moya? Because in Moya-Moya, commonly the recipient beds do not communicate. There's often an obstruction that reaches the stem and the division of the trunk of the MCA. And if a bypass is placed here, it will not go there. So that drove the evolution of my thinking of bypass strategies in Moya-Moya disease, and which culminated into my current preferred bypass for this problem, which is the 1V2A or single vessel double anastomosis. So why is that? The reason, these are the reasons which I'll enumerate and illustrate with examples. First, it is established in the literature that the direct bypass is preferred, and revascularizing as many territories and compartment as needed is logical and endeavored to be done in most cases. So this is the traditional Moya-Moya, this is the traditional ischemia with steel, and here would be the traditional bypass, the so-called double barrel bypass. But let's see what we can learn from the flow. The trunk of the STA, the cut flow with both vessels ripping open, is 41. That's what we can get. We aim to optimize for the donor. First bypass is done, frontal branch, 24 cc's. So the index is 58. We can get more out of this STA trunk. The second limb is performed of the double limb bypass. Another 20 cc's is added, and now we've reached an index of 1. And here's the flow being measured after surgery with the NOVA. The STA trunk is 95. And then the flow in the frontal branch and in the temporal branch are measured separately, and you can see how we can do that. Same, Moya-Moya with hemorrhagic, the double barrel. So that is the traditional bypass. Fills the territories that do not communicate, provides good flow as measured in the NOVA, and fulfills this purpose of directly revascularizing as many territories as needed. And you can see the flow being measured accurately and reliably post-operatively. So what's wrong with that? Why not just stop there? Why change? This is why. Those 2 points. One, it is a progressive disease. We all know the different stages of Moya-Moya. While they may or may not correlate with outcome, it is a progressive disease. And two, if one measures flow over time, as shown in this paper written by my fantastic colleague, Seppi, Dr. Hinjani, what was found is that over time, a number of bypasses for Moya-Moya involute for one reason and another. And you can look at the literature associated with that. But over time, many of these bypasses involute. And if so, would it make sense to use all the available vessels from the get-go at once, or try to think about how to mitigate this evolving problem? And indeed, if one follows their series over time, which we do here, and that's the advantage of sticking around for a long period of time. Whereas at day one, the patency is 96%, Over time, at 1 year or more, it is 74%. So there is a progressive increase in non-patency of the bypass over time. So as we keep this thought in mind, here's somebody that has bilateral carotid occlusion that came to see me and has juvenile diabetes. She was going progressively blind in her right eye because of the association, the double whammy of 1, proliferative diabetic retinopathy, and 2, the collateral coming through her ophthalmic artery through a massive IMAX. We looked at the flow in this IMAX. Mind you, a normal IMAX is 20 cc's at best. In her case, it was 90 cc's. So imagine there's 90 cc's of flow going through her right eyeball. So the goal of the surgery is not only to augment flow, but augment it enough to relieve the pressure of flow through her eyeball. This is the setup. The anterior branch will form a direct bypass, and the posterior branch will stay as an indirect EDAS. And the reason for that is juvenile diabetes, scalp healing, long-term poor patency of bypasses, so belt and suspenders approach. And here's what was done. The posterior branch, as you see it here, was an EDAS, remains in continuity. The anterior branch was a double bypass, a side-to-side and an end-to-side bypass, which I performed on this patient. So that was in 2013. She remains well up till today, and notice that the MMA flow is preserved, but it has decreased. And indeed, here's the flow in the bypass, 167 cc's in that STA. So I think all of you know that we cannot say low flow, high flow. This is actually high flow, but it is an STA. And more importantly, or just as importantly, as a result, consequently, the demand on the IMAX was cut by half. It's 42 cc's now, more than half, and her eye vision improved. Here's another example. In this case, we are looking at the 2 limbs that have been sectioned of the STA, and we're going to envision performing a double limb bypass. However, when we looked at the frontal branch, we have about 65 cc's of flow in it. That's not bad at all. That's not bad. Anywhere, once we hit 60, 70 cc's of flow, that is very sufficient. Especially, this is the other side on the same young lady. Diabetes, concern for poor healing. So if possible, better not use both branches, save it. So that's the anastomosis being performed. And as we conclude, one side being done, we move to the other side, of course. Interrupted versus running, dealer's choice. Depends on how one feels that day. So as we progress through this, we get to the point where the anastomosis is completed. Here it is, the frontal branch. And we check the flow, and the flow was actually quite good. I'll show you the number in a minute. So I decided not to perform a second anastomosis, but rather reconnect the section posterior limb of the STA and keep it as an EDAS to continue to perfuse the scalp in this patient who has potential scalp issues and potential bypass occlusion because of the diabetes. So here's the flow, 105 cc's, 71 in the frontal. Look at the EDAS. It is backwards. It is minus 7 cc's. Blood flows where it is needed, but with the caveat that there's a conduit, and you can see the blood is going from the scalp, high resistance, to the intracranial compartment. Post-op angiogram. Here's the EDAS that was reanastomosed, that's still supplying the scalp. Here's the frontal branch that is a direct bypass. And here's the flow in the frontal branch, 122 cc's. Here's the flow in the EDAS, 19 cc's. How about this patient? In this particular case, which I performed around that same time, 2013, I've showed this at multiple meetings. I was concerned. This is a sickler. This young lady has sickler. So there is scalp issues, there is perfusion issues, collateral issues, and I decided to do this type of surgery. On one hand, one side of it is going to be a end to side with the cut limb of the anastomosis, an end to side bypass. And on the other side, it's going to be a side to side bypass while leaving the vessel in continuity and providing an EDAS. Why? Because of the issues I mentioned. The young person, sickler, high chance of bypass occluding, of scalp problems, sickle crises, and so forth. So here's the final result. The frontal bypass has 35 cc's of flow, not terrible, but good. But the other one has almost 60 cc's of flow. So combined, we have almost 100 cc's of flow, end to side, and an EDAS in continuity. And here it is, the final appearance of this bypass. So as I progressed further, the idea is sinking in. Now, how can we do this but using as few vessels as possible? And this patient comes in, again in 13, that was a productive year, I think. And he has a carotid occlusion, bilaterally symptomatic, but the frontal and the distal branch were very far apart. Initially, I wanted to do a double limb bypass because that's bilateral occlusion. So I wanted to give him a lot of flow. But that STA had excellent cut flow, the frontal branch, and I decided to do the single vessel, side to side, anastomosis first, 67 cc's, followed by an end to side, more distal bypass, which added another 40 cc's. And as a result, we have 110 cc's bypass, which alerted me that time, really illustrated how much we can do with the single vessel double anastomosis. Here's the NOVA, side to side, end to side, 142 cc's of bypass. And then, of course, another tenet is to avoid disrupting collaterals. Here's a more recent patient that we did, one of the few patients we did recently. So the dura to be opened, taking care not to disrupt any of the collaterals. Here's the patient that I showed you, actually. We did that just 2 weeks ago with the cut flow that was compromised by the vein. And then once the anastomosis is completed, taking care to really be cognizant that the collaterals are preserved. Here it is, 50 to 60 cc's, leaving the dural bridges of minimal meningeals, single vessel, double anastomosis with less trauma and less injury to the tissues and less disruption of the collaterals. So we showed that then at the Moya Moya meeting in 2015, the first time we showed that, published that afterwards in various meetings and presentations. And I'll conclude with these two cases to kind of bring it home. Here's one, this is very recent, maybe a week or so ago, bilateral Moya Moya, an adult. And this is what we're calling the Alfred bypass. Actually, Alfred added a bit to it. So we want to preserve this collateral. Notice this posterior branch is collateralizing the scalp. We want to apply the same principles, but the anterior branch is not going anywhere. And I was not able to perform a single vessel double anastomosis here because if you look, there's only one good recipient. The other one is really very poor. So I decided to do one bypass using this side branch and preserving the main trunk. The flow is not unreasonable, it's 30. And the anastomosis is then performed in the manner you're very familiar with. So this is a good branch which is found at the depth. The surface branches are much thinner, much more fragile, and this allowed for a better bypass. And of course, very important to clean the vessel. You can see a little tag here that I'm releasing. And the anastomosis is performed. And once it's completed, we have an index of 1, an excellent bypass, which combines an end to side with an EDAS in this patient who has Moya Moya. And you can see again, flow in the bypass, flow in the EDAS. Here it's bidirectional, illustrating the high resistance of the scalp. And here's the flow in the NOVA. Look at the flow in the STA trunk, 129 cc's going towards the brain. Here's the flow in the bypass, 97 cc's going towards the brain. And this is the EDS. Now it's smaller. It's only 6 cc's, and it oscillates around the 0 line, to and fro, like you saw, because of the Rihari resistance. And here's the post-op of what we're now calling the Alfred bypass. The last case is a lady with a carotid occlusion, multiple symptoms, require the bypass based on all the hemodynamic and recurrent symptoms. But what is the problem? There's a confounding problem here, additional problem. Her collateral is coming mainly from the left, across an A1 that has an almost 90% stenosis. Now, what happens if you bypass across a stenosis? There's a big concern that the stenosis, the pressure gradient across the stenosis would drop, and this stenosis can progress to occlusion. So we had to make sure that this bypass, which is a flow augmentation bypass, would also replace at least the flow that is coming through this right A1. So that's why we conducted the surgery. So we measured the flow. This A1 is providing 60 cc's of flow negatively. So we need our bypass to provide at least 60 cc's of flow. So we measured the cut flow in the distal parietal branch. It's only 26. And based on that, we elected to go more proximally to see if we can fix that. That's the trunk of the STA. And once that is done, we measure the flow in that trunk, and it is 62 cc's. It went by a little too quickly, 62 cc's. So now we know that we have enough bypass to replace this A1 collateral flow in case something bad happens. So the bypass is then performed with the confidence that that STA can provide, and it does. Remember, we wanted about 50 to 60. We have an index of 0.9, and here it is, the completed bypass. Here's the ICG, and very importantly, here's the NOVA flow. The bypass, as you see here, is 59 cc's, and that is supplying, look at the ACA flow, it dropped from 60 to minus 24. So it definitely dropped as we anticipated, but we're confident that this bypass now was enough, as we demonstrated at surgery, as we will follow post-op, was enough to support the flow needed. So it is a complex system. And the surgery has been done for a while, for more than 50 years. For ischemia, certainly for atherosclerosis, if anything, the data shows that it's not necessarily effective. Doesn't hurt maybe, but maybe it doesn't help. Yet it endures. And I think we have an idea why. It's the Everest that many microvascular surgeons seek to climb. It's aesthetically gorgeous. And to paraphrase Voltaire, if it didn't exist, we'll have to come up with it. That's really a very, very big reason. But that is the why we do it. That is the why we're driven to do it. But we have to remember that this surgery is a means to an end. And blood flow is, augmentation is a means to an end. And the end is to achieve better outcomes and to understand this disease and its physiology based. And there's a lot that we don't know. So blood goes where it is needed. Yes, if the bypass is done for the right reason, if we understand why we do it, if we document what happened, and if we can correct for all the failures, anticipate them beforehand, I think Hunter is right, and bypass will provide blood augmentation to go where it is needed. It's time. It's been truly a pleasure to be with you with this. I congratulate you, Jacques, once again, and team for putting together this educational program. And I look forward to listening to the rest of the talks and being with you going forward into the future.
Thank you, Fady, very much. That was a fantastic tour. I know you could talk for several hours on the topic, and we'll save questions for after Mike's talk. Mike, if you could share your slides with us so we can now cover, we covered ischemia and moya. Let's cover now bypass for aneurysms. Are you on mute, Mike, or you're okay? Mike, you're muted.
Can you hear?
Yeah, now we can. Yeah, if you can share your screen.
Okay. How about that? Can you see that?
No.
Hold on.
What do you guys see? Oh.
How about that?
Yes.
Okay. Well, thank you, Fady. Thank you, Jacques. I appreciate that very kind introduction earlier in the program. And I do just want to say that Jacques and I do share a common origin story. We went to Phoenix at the same time. Jacques was here for probably a year and a half of overlap during my residency. And I was young and impressionable, and we are a byproduct of who imprints us early on in our careers. And I was lucky to have been imprinted by Jacques early on. And we've been friends ever since. It's been a real pleasure. And thank you for having me to be part of this. So I'd like to start with this slide. Because if you look at the numbers, you would say that vascular neurosurgery is in a pretty good state of being. And I've been quite blessed to be able to do all of this. But if you look at the next slide, what you notice here is the aneurysm curve year by year looks pretty solid. But if you plot it out over on this graph to the right, what you see is that there's been a peak, and the curve is now trending downward. And I think it's a reflection of the fact that in this endovascular era that we live in, more and more aneurysms are being treated endovascularly, and our open neurosurgical case volume is shrinking drastically. That led me to do some writing. I'm a believer that the pen is mightier than the scalpel. If you do good work but nobody knows about it and you don't publish it, then its value diminishes, except for the people that you treat. So I made a concerted effort to try and capture some ideas down. And you know, when I did my first book on aneurysms, I really felt like that declining curve was a motivator, that we were going to reach a point where open aneurysm surgery would be really threatened, and we should really capture all that we've learned now before all of that knowledge and wisdom evaporates. My metaphor for that book was dancing, because it's not that I'm a good dancer, and Jacques can attest to that, but it's, if you take a complex act like dancing and reduce it into a series of sequential steps, then I think it becomes something that's reproducible and understandable, and will help a lot of people to perform it. So this is some of the artwork from the book, and this is your classic middle cerebral artery aneurysm approach. And what was really nice about that whole dancing metaphor was that it broke down the various steps in an operation into these numbered, ordered steps. And so I thought it was a very nice way to teach people how to do this, or at least for me personally, to capture my own thinking about it and try and, you know, distill that experience that I showed you into something that was valuable to others. And so that really was helpful. Now, I showed this paper because this was a giant aneurysm paper that we published nearly a decade ago. And what's interesting about this is that if you look at this particular case as a segue, this was a giant aneurysm that I clipped. You can see it's this nice picket fence reconstruction. You can see I got a good result, but here's the 5-year follow-up. And on the 5-year follow-up angiogram, what you can see is that the part between the trunks was dysplastic and continued to enlarge. So the treatment for this aneurysm now escalates from a clip reconstruction to a bypass. And this is a demonstration of what I call the creation of a middle communicating artery, which is a bypass with a graft, an interposition graft from the neck, and then bringing the two trunks off of the aneurysm and putting them together so that they can freely communicate with one another and distribute the flow as needed, as Fady suggested in his talk. So here now is the operative video. This is just the placement of the proximal end of the radial artery graft in the neck. This now is back in the sylvian fissure. And you can see what we're looking at here. This is the temporal division of the middle cerebral artery coming out of the aneurysm. And this graft did not have enough length to do a double reimplantation like what Fady showed in one of his drawings. So what I did instead, I just made sure that this temporal division had the flow that it needed. And you can see here on the icy green that it does. But now, if you think, we usually don't use the other proximal end of that trunk. We just do our distal occlusion and we forget about it. But if you repurpose that and reimplant that trunk over to the frontal division, your trunk becomes its own internal bypass. And this is really an end to side reimplantation. And you can see the inside suture line. You can see here the two anastomoses. And now we've reconstructed that middle cerebral artery bifurcation in such a way that we can distally occlude that. That was just to show some lenticular striates on the back side that prevented a complete trapping. But here is the distal trapping, distal occlusion, and you can see on icy green and on the angiogram that we've got good flow. So that case I show you just to raise the question, are these giant aneurysms best treated like regular aneurysms, or are they a completely different entity that requires a different way of thinking about them and a different strategy? And I think what that case hopefully proves to you is that, yes, we do need a different strategy when we come to these complicated aneurysms, these giant aneurysms. And you can see here the numbers of bypass for these. Here is my experience to date, 235 cases, and the bypass number or percentage here in that group of patients is 44%. So I think my experience speaks to that philosophy that there is some threshold where an aneurysm changes from the traditional saccular clippable aneurysm to one that is beyond that and needs something different. So that's where I got to this book. And these were sort of my goals for this project. And I wanted to develop symbols to translate our ideas. I wanted to develop a taxonomy. I wanted, really importantly, to advance these intracranial to intracranial techniques, techniques that aren't as valuable in the ischemic setting, because in the ischemic setting, you need to bring blood from somewhere else into the brain, whereas for the aneurysms, you can just tap into vessels that are in the neighborhood. My metaphor for this was architecture, and I give you this picture because this was my view in my morning runs in San Francisco. I lived there for 20 years, and when you run down the trails to Kirby Cove, this is the spectacular sunrise view that you get looking underneath the Golden Gate Bridge to the skyline. And the point for this slide is that if you look back at the original designs of the Golden Gate Bridge, they were really quite inelegant. They had large trusses, they were really clunky looking. And at some point, the architects decided that they were just going to scrap that original design and come up with something more majestic. And so they transitioned to this suspension design. And you can see this is 88,000 tons of steel that's suspended by these very thin wires. And this span is 1.7 miles across the water. It was, at its time, the largest spanned suspension bridge in the world. And it really speaks to the fact that if you're going to do a job, you can do it in two ways. You can do it in the pragmatic way that may not have an artistic flair, or you can do it in a way that's incredibly elegant and proves a point. And so that's really the message here, is that you know, when I think about the opportunities that we have in bypass surgery, it really is like the Golden Gate Bridge. It's a way to transform a surgical procedure that we do routinely from plumbing to art. We can use it as a way to express creativity, express our personality, express that passion that Jacques alluded to for doing neurosurgery. And I also think that if you're going to stick your neck out and try and make a bold statement, whether it's architecturally or surgically, you have to hold yourself to a higher standard of perfection. And certainly these bypasses do that. Now, one of the things that I got to thinking about was that if you were to build a house, you have to go from some vision, some idea of what you want that house to look like, and develop it with your architect, work out all the details, communicate it to your builder, and then have them build that construct exactly the way that you expect it to be built. And they do that by developing or capturing those ideas on blueprints. So you can go from the concept to the house without any major glitches. When I was thinking about our bypass situation, what I realized is that we don't have a similar kind of blueprint. And so one of the things that was important to me was to develop symbols. This is a summary of those symbols. And if you spend some time and you learn these symbols, it allows you to essentially take any bypass design that you can think of and represent it with these various anastomotic symbols, with these various graft symbols, the different vascular territories over here to the right, the ACA, the MCA, the basilar, or the pica territories. And you can construct that symbolic representation of your construct and communicate it. Now, what I've noticed since doing all this is that it works. There's no doubt in my mind that it works really well, but it's not as easy to use that as, let's say, an architect's designs when they build a building. There's a lot of software, and architects are schooled in all the different symbols. And so it works in that profession, but in our profession, it's a little bit harder. So this slide is meant to say that we can take this down another level and really boil down bypass architecture into code. One of the things that Al Lawton stopped short of doing was he gave us these nice alphanumerics for the cerebral circulation, did not do the same for the posterior circulation. So he and I worked on this. We decided on the lowercase representation of that. And the reason to do this was that when you have a very complicated bypass like this, for example, here's that blueprint up in the upper left corner. But you can also express that design here with the code. So if you were just given a slip of paper with this alphanumeric code and had to go to the operating room and perform this bypass, you would know exactly what to do. And this is the intraoperative pictures. I'll show you this case in a minute, but that was the intent. Jacques said I'm obsessed with 7, and I think maybe he's right, but it's always served me well. And in bypasses, you can see the 7 different types of bypasses here, spanning from what I would call the first generation scalp bypasses that Yassergil introduced to us, the second generation graft bypasses, interpositional bypasses that use the cervical carotid that Sunt popularized. These are these next intracranial to intracranial bypasses, 3, 4, 5, and 6. And then finally, you know, as we stretch our wings and do these more complicated bypasses, we realize that you often need combination bypasses. Even in what Fady showed you for ischemic solutions, these combination bypasses are increasingly important. So I think you can see that this whole way of looking at bypass starts to take shape. These principles have ways of expressing themselves. You can classify aneurysms very distinctly, like this illustration of the different types of middle cerebral artery aneurysms. You can then reduce the different surgical options into this grid menu, where you have the locations here up at the top, and going down the columns, you can see each of the different 7 bypass options and make selections based upon the different choices. These are also some algorithms that I tried to put together, just answering critical questions that might lead you to the right choice. So here's just a case example, and I'm gonna jump through this in the interest of time, but this is an example of a giant middle cerebral aneurysm. The The treatment for this is essentially just a wide Sylvian fissure split, expose both of the M2 trunks as they come out of the aneurysm. And here what we're looking at is the A1. The A1 anterior cerebral artery, in my opinion, has become a really important intracranial donor site, because when you have a good anterocommunicating artery, you can temporarily occlude this, and there really are no ischemic consequences. So you can sew your radial artery graft to the A1 segment here, and you can arterialize that graft. And then once you've got that in place, you can then run the graft up into the Sylvian fissure. Now here, our aneurysm is over here. Our trunk coming out of the aneurysm on the frontal side is here. And this is now an arteriotomy in the graft that we're going to bring together side to side with that trunk. So this is basically a side to side reimplantation onto that MCA trunk coming out of the aneurysm. So I'll just show you a couple of seconds of this to show you how, if you look really carefully, I'm sewing this side to side anastomosis intraluminally. My sutures are on the inside. It's not your classic extraluminal suture, and it's also a continuous style. And in this manner, we can get our side-to-side anastomosis completed. And jumping ahead to the temporal trunk, you can see here, this now is the trunk coming out of the temporal side of the aneurysm, and the end of that graft is being sewn to the temporal trunk. So here now, after the bypass is in place, there are 3 separate anastomoses. The aneurysm can be occluded proximally and distally. You can see the trapping clips, and our bypass now has taken over. So here's the overview. This is our icy green, showing everything's patent. And then since the aneurysm is completely isolated, we can suction decompress this thing. It's completely excluded from the circulation, and we have everything taken care of. So that's an example of this application of symbols, alphanumerics, code, blueprint, however you want to describe it. It's just this way of thinking about bypass architecturally, and then really taking it to the OR. Now, the rest of the talk is really about evolution, because I believe that this is one of our areas in vascular neurosurgery where we can grow it. It's exciting, there's novelty, there's the ability to do things that haven't been done before. This is a constructive procedure rather than a deconstructive operation like so many of our other procedures. So I'm going to just show examples of how, if you embrace that attitude about pushing the envelope and doing unique, novel bypasses, you can evolve the craft. So this is the ICA bypass story. And when I wrote 7 bypasses, I really didn't even talk about ICA bypasses. I talked about MCA, PICA, Basilar, and ACA. And ICA really was an afterthought. But I was thinking to myself, well, if anyone's going to believe that this framework has value, then I should be able to apply it anywhere, including the ICA territory. And so here are the ICA aneurysms and all the different 7 bypasses, the different forms that I've done now for ICA bypasses. I'm just going to show you one of those. It's this lady here. This is a thrombotic proximal ICA aneurysm. You can see it's nearly giant. It's thrombotic, compressing the pons, and she was symptomatic from that. And if you look, this is just an extended retrosigmoid approach. This is my fellow looking for pica, and he wasn't able to find it, but when I came in and looked a little bit higher up, I was able to see that it was not only there, but also quite robust. Here it is. This is pica here, this is ICA there. And the beauty about these 2 arteries is that they come together very nicely in parallel. So these become a natural side-to-side donor and recipient pair. And so this is an ICA to pica, or rather a pica to ICA bypass. You can see the standard technique. It's these linear arteriotomies are anchoring sutures at either end. Interluminal suture technique. This is tying things down. We'll start with an entrance stitch, which you can see here. We'll then run that interluminal suture line from one side to the next. And again, I'd remind you, this is just an extended retrosigmoid craniotomy. This isn't a transpetrosal. This isn't anything particularly overly invasive, but you can see you can perform this bypass, you can bring these vessels together. And the strategy here is to get the bypass in place. Here we have it in place. And now we can really get to the meat of the operation, which is to turn our attention up here to the aneurysm. The bypass is here. Here now, you're looking at ICA as it comes from the aneurysm. This is the 6th nerve draped over the ICA outflow. This is the 7th and 8th nerve. And my first clip here is a distal trapping clip. My next clip is going to be right at the ICA origin from the basilar. So as I go medial to this aneurysm, I'm looking for basilar, which is right in here. And you're going to see right in this area here, just enough ICA to apply that proximal trapping clip right there. You can see it right there. So the clip goes on, that traps the aneurysm. And now the aneurysm is completely excluded. I can get out my CUSA and do a CUSA decompression, which you see here. That reduces this aneurysm to basically an empty sac. And you have this really nice overview with the bypass here, the trapping up here, all through the extended retrosigmoid approach, and the icy green shows this retrograde filling up the ICA to supply that distal territory. I'm going to skip this one. This is just an ICA end-to-end reanastomosis, and I'll turn my attention now to the ACA territory. This was a paper that I wrote with Adib a number of years ago. We published these 10 ACA bypasses, and what's interesting is it was about, well here, you can see the period of the first publication was 16 years. We did 10 bypasses. In the next 5 years, we did 13 bypasses, and not only did we really expand or accelerate the numbers, but we experimented with things that I personally hadn't done before. These are examples of different in situ bypasses that join, for example, the A3 and the callosal marginal, or the callosal marginals here, the pericallosals here, or the A3 is the classic A3 to A3 bypass. Here's a double bypass that joins both the pericallosal and the callosal marginal. And these are some of those cases. This is that callosal marginal to callosal marginal bypass. This is that A3 to callosal marginal bypass. And the reimplantation is the same idea. When you think about how nicely suited these parallel arteries are for moving from left to right, you can very easily take them off the aneurysm and reimplant them on the contralateral side, and that allows you to then trap these aneurysms. These are examples of that. Here's this fusiform, nearly giant aneurysm with this outflow artery that was easily reimplanted to that adjacent opposite side. We talked about the A1 ACA as a donor site, and I think that's a really important advance for the ACA bypass territory. I'm not going to show you this because we've already covered that, but you know, there are others. These are azygous bypasses that again use this double reimplantation technique where you first arterialize a graft and then do a double reimplantation style bypass to revascularize the branches. So here's the first period up here in the upper left. In the middle of the slide here, these are all of those more recent cases. And again, this shows you the ability of these blueprints to articulate exactly what was done, or if you prefer the alphanumeric code, you can express the same thing over here. So after writing the book, I also gave a lot of thought to where we're going, and some of my good friends like Howard Rena said that there is no such thing as a fourth generation bypass, that our days are done and that the pipeline is really the future. But I wanted to just go back to that first or early case that I showed you, this one here, and remind you that when you look at that first reimplantation, that was a side-to-side reimplantation. A reimplantation is classically done as an end-to-side anastomosis, whereas this one was a side-to-side. And then if you look at that second anastomosis, that was the end of the graft sewn to the temporal division. And that was an end-to-side, which is your classic reimplantation. But I sewed that all interluminally on that first suture line. And that really is an application of a different technique than what you would normally use for an end-to-side anastomosis. So when you think about those concepts, really what we have here are a way of thinking about a new generation of bypass. And I like to think about them in two categories. The type 4A is when you do a conventional construct, but you use an unconventional sewing technique, like that in situ technique that I just showed you. The first example in that particular case was an example of a type 4B bypass, which is an unconventional construct, the side-to-side rather than the end-to-side, but created with conventional or unconventional techniques. These are details that essentially get lost unless you call them out and you include them in part of your labeling of your bypass. So again, getting back to the architecture, if you're going to have complete communication with your construction crew or for posterity, you really have to include a level of detail that's missing from our current discourse. And when you think about that bypass, that fourth generation bypass, you can see how these are the 7 bypasses here laid out in this table. But there are numbers of ways that you can do these fourth generation bypasses. For example, you can reimplant arteries end to end rather than the classic end to side. And I'm going to show you examples of these because I think it's just easier to see it done. Let me skip this one here and go to this one. This is a reimplantation bypass. It's an MCA aneurysm. And if you think about that double reimplantation technique, this is your classic type 3 reimplantation. You've got you know, a bypass coming in and you take one trunk off and you do this sort of reimplantation style thing. But you can do it in a number of different ways. If you do your anastomosis interluminally, it becomes this 4A. If you do these reimplantations in that side-to-side manner or with an end-to-end, you get different constructs altogether. So here's some examples. This is a very dysmorphic MCA aneurysm. For this one, I'm going to use a double barrel STA-MCA bypass. I'm going to bring each of the STAs to these 2 trunks that come from the backside of the aneurysm. And then you'll see when you view the video how there's tremendous caliber mismatch between the recipient and the donor. And so in order to get around that problem, I add on this end-to-end reimplantation. So these 2 ends are reimplanted to one another. They're creating this middle communicating artery here. And that allows the flow to redistribute itself around that communication as needed. So these are just double barrel STA-MCA bypasses. There's nothing real fancy about this. So let me just jump ahead here. This now is the aneurysm after the 2 STA-MCA bypasses are in place. I'm transecting each of the 2 trunks out of or off of the aneurysm. And so we have this free trunk here on the temporal side, this free trunk here on the frontal side. And by bringing them together, we're creating this communication. Again, you see this is a type 4A because it's sewn interluminally. And this is what I would call a type 4B because it's a reimplantation, but it's end-to-end. It's not your classic end-to-side. So here's the completed anastomosis. We can remove our clips. We now have the ability for those double barrel bypasses to then circulate around the communication and distribute flow as the demand calls for it. Here's another example. This is that case I showed earlier, but this one I want to show you. Again, another middle communicating artery. And this one, we're going to do an even different style. This is all intracranial. So unlike the first one, which was a ECIC high flow graft, and unlike the second one, which was a double barrel STA-MCA bypass, this one is going to be all intracranial. We're going to use the A1 over here as our donor. We're going to use this short jump graft. It's going to revascularize one of the two trunks. And once that's taken care of, then we're going to do an end-to-end reimplantation and bring those together. So this is the view of the aneurysm in the sylvian fissure. There's the M1 underneath feeding in. This is just the suturing of the radial artery graft to the A1 segment. So this is our intracranial donor. Now we bring the other end of that graft up to the temporal division, and there our bypass is completed. So now we have a working bypass. And now we don't have to go down to the neck. We don't have to expose or tunnel. We just need to take the two trunks off of the aneurysm. So this is transecting the first of the two. Here is the second of the two. You can see this tissue is quite fragile. Very atherosclerotic tissue, certainly not amenable to clip reconstruction. And now we can transect that frontal trunk off of the aneurysm. We can flip the aneurysm out of our way. And now we can bring these vessels together with an end-to-end reimplantation. So this is an example, once again, of this middle communicating artery concept, where the communication between the two trunks is allowing for one bypass to revascularize the entire circulation. This is also an example of a type 4A. This is an interluminal suture technique. The vessels had very little extra redundancy to allow the tissues to move, but you can see that at the end of the anastomosis, we have a nice joining of the two. We've got our icy green here, which shows communication patency here. Here's our radial artery graft. And this is a nice, successful middle communicating using that end-to-end technique. And here, just overview showing the construct, and I'll take it to the end here. Here's the angiogram postoperatively showing a nice construct. So those are all examples of ways that we can really expand our armamentarium. This next slide is just all the different ways that, or all the unusual bypasses that have crossed my mind that I'd love to try and do someday, but haven't yet done. And you can see that there's a long list. It's a field that's very ripe for creativity. And you know, that's really one of the messages, is to let you see that this is an area where we truly can innovate. I put this slide in to remind you that you know, a lot of these ideas require vetting. You've got to go to the lab. You've got to look at the feasibility. You have to look at the anatomic limitations. You have to try to see how comfortable or uncomfortable it is to do these things. And at the end of the day, then make your decision about whether or not it's reasonable to do that. So this is a graph like what I showed at the beginning. And I put this on here to show you that if you look at bypasses, the trends are really quite favorable. You know, when I started my practice in the late 90s, I was doing roughly 10 a year. And you can see right now, it's around 50 per year, give or take. So it's a practice that I think is in growth, not in decline, like open aneurysm surgery. And these are just some concluding thoughts. I like the bypass operation because it speaks to the constructive power of simple suture. This is not like so much of our other areas of neurosurgery where we rely on high technology, where we need teams, multidisciplinary teams. This is just simple suture and technique. And I am a real fan of this whole craftsmanship element of bypass surgery. I also wanted to impress upon you just that you can innovate here. This is not a stagnant field. There is so much opportunity here, and you know, it just the only limitation is your own hesitation and your own creativity. So that's really what I see as the future of vascular and bypass in particular. I think it's a tall order. I think that, you know, the manual skill development that you need to work through to get confident doing these different procedures is quite high. It takes a lot of practice. But you know, I do believe that what makes it so great is it really stimulates the head and the heart. You know, you have to be thoughtful. You have to think through your strategy. You have to be creative. You have to, as Fady mentioned, make sure your indications are solid and have good judgment. And then heart, you know, these are tough cases. They don't always go smoothly. You can have defeats. You can go for that unusual bypass and find yourself struggling. But it's constantly pushing us. And I think it makes us strive for that perfection. So I'm going to stop there. It's been a pleasure to speak with you. Jacques, thank you for having me. And this was great.
Thank you, Mike. Thank you very much. If you could unshare your screen, that was a very nice overview of the entire bypass for aneurysm. Thank you so much. Oops. Okay, you guys, you see my screen or no?
No, doctor, you have not shared anything yet.
Okay, sorry. Okay, so we have excellent panelists. I'm gonna just start the discussion with a case, and then after me will be Niraf, Patel. So let's see what our speakers think of this. Fady, particularly I'll address it to you first. This is a case of, I'm going to go fast, of
angioma, which was previously
a 50-year-old unresectable residual skull-base meningioma, status post left-sided cranie many years ago with radiation. Bottom line, she's presenting with radiation vasculopathy and multiple TIAs of that hemisphere. Seizures were ruled out. Here is her unresectable meningioma encompassing the basilar and so forth. And you can see ischemic changes in the left cerebral hemisphere. Here is the MRA showing no real visible MCA. Here is perfusion studies. You can see the misery perfusion. I'll go straight. This is the angiogram. Please notice the external carotid. You can certainly see the IMAX there. You can see middle meningeal artery attempting to collateralize from the IMAX. There is
very robust. It was thought to be a good potential donor vessel.
Here we go. So why don't I stop here, Fady? If you're not muted, could you tell me what would you recommend for this patient who's having ischemic changes on the left hemisphere and no STA, and attempt at collateralization from the middle meningeal via the IMAX?
Yeah, that's a great case, Jacques. So it is given then based on the clinical presentation, as well as on the radiographic and flow imaging data that this patient is in need of a flow augmentation.
Yes.
Since the options regarding a conventional STA are non-existent, one must look at alternatives. Now, in this scenario, the average flow augmentation required in patients such as this, based on previous work done primarily by Peter Schmidt, who was the boss of Peter Peshkozy, is around 50 to 60 cc's at the most. So if one is to use a native vessel, we see that there's a good occipital artery here that might collateralize through PL collaterals. I think this is not a bad option for her. And that would avoid then reopening a craniotomy area that would have been compromised with adhesions and scarring and so forth. So that is one option. I think there's an auricular, a posterior auricular branch
Very small.
Very small, okay. And the other option would be to then perform a interposition graft. Of course, you could consider the IMAX, but that might put you in proximity with the tumor and having to get into a lot of scarring there, but that certainly is an option, and an interposition graft from the IMAX to branches of the middle cerebral artery. But again, it's an ischemic brain, and less dissection might be preferred. And I would look at the occipital artery and use that first and see if it collateralizes through PO collaterals. And that would be helpful. And if not, then maybe at a later stage, a interposition graft, either from the STA stump, maybe from the STA stump.
Yeah, great. Again, for the sake of time, I will speed through this. I was thinking IMAX. I did not want to disrupt whatever attempt there was from the middle meningeal artery to give collateral supply. So I did go for the occipital artery, which the audience can see here on your right side. And those were the options that I was considering, the 4 options: ECA to M4, occipital to M4, ECA or vertebral to M4 with interposition graft, or an indirect bypass, but the patient was really having multiple TIAs. I did not want to wait for an indirect bypass to mature over time. And this is really just to remind us of the availability of the occipital artery when you don't have an STA. I also had the radial artery, the arm prepped. And again, now the occipital artery really can reach to the angular artery and not much further forward. And here is the angular artery. And again, you need to create a tunnel in the bone because, of course,
easier to perform now?
It will occlude. I felt it could occlude from the skin. So anyway, we've seen enough bypasses. This is my fellow narrating the video, but bottom line, that's what I did. And at the conclusion, that's what it looks like. I wouldn't be able to get much further forward than the angular artery.
Leading from side branches.
So that's really what I wanted to show you post-op.
Looks like you measured flow. Do you recall what it was? I'm curious to know how much.
Yeah, is it not? I know I have it, but it's probably not edited in the video. But I think 35, Fady, if I remember correctly.
Yeah, that's pretty good.
Yeah, yeah. Here we go, and that's the post-op angio. So please remember again the audience, occipital. Talking about. Mike talking about kind of unusual bypasses. Always be open-minded about what you can use when you don't have the traditional thing. I stopped sharing my slides.
Can I ask you what your harvesting technique is? Do you do the layer by layer muscle dissection, or do you do the inside out?
Inside out? No, in this one I did layer by layer. I did do the technique you and Arnaud, isn't it? His first name, Arnaud? Yeah. Described very, very smart way to do it. I've done it a couple of times, but I've done this one to start distally to identify it and then carried it on with the Colorado needle. Okay, I stopped sharing my slides. May I ask Niraf Patel to go ahead with his case?
Thank you. Thank you, everybody, and Dr. Morcos for letting me and others learn from your guests today. So I've got a case prepared, and we'll make it short I guess, for both the speakers, but it's an aneurysm case. And so 60 years old, comes in with...
Niraf, can you click on play? Yeah.
Sorry, thank you.
Yeah.
So she's 60, comes in with a family history, dizziness, and some syncope type events, but has this aneurysm, as you see on the left of her brain. It's 2.5 centimeters. And I think it's just an M1 aneurysm where both the M2s come out later. This is the AP and lateral angiogram. I think Dr. Lawton showed a similar case. See how I didn't do it as well, but There it is. And then this is the 3D. The branches of the MCAs come out later. So it's an M1 aneurysm. So before I get to what I did, I guess I'll ask the speakers, Dr. Lawton, what do you suggest here? And I'll show you what I did too.
Yeah, I can't tell you how many times I've gone into aneurysms like this thinking that I was good enough to clip reconstruct and that it would just be a short, easy case and failed miserably. So I've learned my hard lessons, and I think that this is just a bypass case through and through. There are a number of ways you can do it. You know, the most elegant way would be an interposition M1 to M1, but as we all know, those lenticulostriates that are potentially in the way make it really dangerous to occlude the M1 segment for that kind of a bypass. So,
sorry, Mike, 1 second. Niraf, can you point with your pointer to the audience what Mike is talking about?
Yeah, I think that's a great point. You know, this is the M1 segment, and then the aneurysm, and there's going to be lenticulostriates here, even if you don't see it on angio, but they're certainly there, and my next slide shows you exactly his point. Yeah.
Go ahead, Mike.
Yeah, so there are a couple ways you can do this. I mean, I think the A1 M2 bypass that I showed you is a really nice way to do that because you can put the bypass into the A1 and then jump it around to the M2 a little bit away from the aneurysm. And there's essentially no worrisome ischemia time when you do it that way. And it's 2 anastomoses, it's high flow, there's no need to tunnel or dissect down to the neck. I think that's a nice way to do this. You know, sometimes you get lucky with these. The lenticulostriates can be pushed to the side, and you might have redundancies in very rare cases to pull these together end to end. It's curious in this one because you got some extra loops there at the end, but I don't think this will do that. I also think that you'll have those lenticulostriates that will be on that aneurysm base. So I think you may be limited to a choice between either a proximal occlusion or a distal occlusion, but not a full trap.
Yeah.
Niraf, before you tell us what you did, Mike, if a member of the audience has done 10 or 15 bypasses in their career, and you're advising them, like, what would be the safest bypass for them to do on this case? Not the 4th generation. What would you recommend to them?
Yeah, so the first times that I dealt with this aneurysm, I would have done an ECA to M2 bypass. The ECA anastomosis is easy. It's your classic 2nd generation bypass, and you just tunnel it up to the distal sylvian fissure. You pick an M2 trunk, usually the temporal one, a good sizable one to sew into as your recipient, and it's a very low risk way to do this. And that's how I think, you know, if you're at number 15 in your learning curve, you should probably do that.
Okay, Nirav, tell us what. Oh, go ahead, Nirav.
Yeah, thank you.
Or Niraf.
Fady.
Yeah. So this is, as was mentioned, this is a flow replacement bypass. What I would like to add is something that derives from having measured flow on these aneurysms, distally. The larger the aneurysm, and this is not a small aneurysm, interestingly, the flow that needs to be replaced distally is less.
Right.
While it may appear that this is an aneurysm that needs a quote-unquote high flow, it may not be so. And there's many examples that I've shown that the larger the aneurysm, collaterals develop because imagine how much time it takes for this blood to circulate to go and eventually perfuse distally. So you might be surprised. So the way I would approach this is by measuring flow in the M1 distally or the M2 branches, putting a temporary clip and determining the deficit. And one might be quite pleasantly surprised to find out that that deficit can be replaced with an STA, which is right there in the field. It's a low risk procedure. And then of course, afterwards dealing with the periphery is another story. But But if one approaches it from the perspective of flow replacement, how much flow is needed, and looking at the simplest way to do it, which, as Mike said, would be an STA bypass, which could be done distally here. The beds communicate. You don't have to go deep in the fissure. That might be a very simple, and not just for the beginner, I would say the most appropriate bypass in this case.
Thank you. Yeah, those are both really good points. I didn't do testing. I used the Saphenous Vein because I just feel like that's enough blood to augment that, to replace the entire left sylvian fissure. Let me see if I can go to the next one here.
Is it advancing? Oh.
Yeah, there it goes. Okay. So as was mentioned by Dr. Lawton, these are the pictures I put in at surgery because those are the lenticular striates, and some of them are coming off the back of the aneurysm there. And so I was also concerned about, you know, losing one of those, which can be real devastating. So we were prepared for that graft. And this is the M1, Saphenous Vein. So as he said, like a second generation bypass. Saphenous Vein is brought up. This is the M1. You know, the fissure has to be widely open first, but there's those lenticular striates, and they come even more distal. So they're worrisome about putting them together with the end-to-end. So instead here, you know, the M1 presents itself pretty well just before the bifurcation. The graft is sewn in, and then I put the proximal end of the graft to the common carotid because that's the way I learned it, but I know there's a lot of different ways. So what happens next? I leave a permanent clip just distal to the aneurysm because I can't trap it for fear of the lenticular striates. I feel pretty good about it. Here's some post-op imaging. You know, you can see the graft, you see the distal clip. Picture on the bottom illustrates the view. And here you even see post-op day 7, the aneurysm shrunken down. Post-op day 21, it's looking real good. I'm happy with everything. And here's the thing, you know, she's 5 weeks, then post-op, you see the aneurysm's back, and there's a very large mass. There's even a hemorrhage posteriorly. It's growing at 3 months. So it's a curious finding. She's got a bunch of new edema. She's symptomatic from speech. So ultimately, you know, I feel like this isn't going to get better. I do this angiogram. There's filling of the aneurysm that wasn't filling just after surgery. It's growing. And the graft itself is looking very, very poor.
I have one problem.
So then what happens, and I appreciate that comment, what happens, I'm thinking about this, well, how do I fix this? I got to get rid of this aneurysm. So I end up packing it with coils. And right on the table, you know, the graft looks a lot better. So where's the competitive flow here? I'm not sure. But when I take down the aneurysm and potentially those lenticular striates, graft fills. And luckily, she has no neurologic deficit from that. And you see the progress here with this MR. There's a post-op, and then 2 weeks, 2 months, it's getting better, but then 5 months, and I showed you this is after coiling, and then now at 2 years, she's back to normal. So something happened immediately after the distal clip occlusion that set into motion an unusual path that I did not predict pre-op. And I guess if I was doing it over again, maybe I would have just done a proximal occlusion, but it's not, you know, that doesn't happen very often. I was interested to know the experience of our guests, the distal clip occlusion causing this kind of a sequence of events.
Fady first, maybe, and then Mike?
Niraf, this is a very nice case. You know, it illustrates the difficulty with bypasses for aneurysms. In a sense, I'm quoting David Langer. I think David Langer said that first, or I heard it from him first. He said, the surgery starts after you do the bypass. The easy part is the bypass in a way. What happens afterwards is so unpredictable. So I have seen it. We've even published a series, I think, with Jacques and Luca, combining cases where the bypass not only grew but ruptured after distal occlusion. I mean, the aneurysm ruptured after distal occlusion. Luckily, this one didn't. I don't know what causes that. That's the honest answer. But obviously, you managed it well, and there must have been something that caused the flow to increase, which resulted in the flow in the bypass to decrease. And the evidence of that is once you corrected it, the flow in the bypass increased. So something must have happened to increase flow. Some channels may have opened up. I'm making stuff up right now, to be honest. I don't know, but luckily you pulled it off. It's great.
Mike, comment?
Yeah, I have two thoughts. Well, first of all, I too have had cases of distal occlusion that have ruptured. In fact, the most dramatic of mine has been a M2P2 bypass that I put in place and was taking pictures of this beautiful bypass and getting ready to start closing, and the aneurysm exploded 5 minutes after I finished, and the lady died. So that's a dramatic reminder that if ever you can do a proximal occlusion rather than a distal, which I think you probably could have in this case,
yeah,
that's preferable. I think the thing that's not clear to me and is worthy of talking about is your anterior temporal artery. You had a really nice anterior temporal artery on this case, and it's quite possible that when you did the coil occlusion, you took out the anterior temporal, and that was your collateral. You took it out, and then that reactivated your bypass. I would also say that the anterotemporal artery, going way back to the beginning of your thought process, because it's such a nice donor that's in your field anyways, you could have, to Fady's point, done a simple STA-MCA bypass plus an ATA-MCA bypass, a double bypass using the anterotemporal, and revascularized 2 of the M2 trunks if you felt like you needed to increase the flow of beyond just the STA-MCA bypass.
Good points. Thank you.
Yeah, I concur with this distal occlusion. I have a dramatic case of a giant aneurysm that ruptured 18 days after a bypass and distal occlusion. I think it all has to do in our poor understanding of the eddy currents and the hemodynamics that form inside these aneurysms that can actually cause them to rupture. I agree, whenever possible, you know, you do proximal occlusion if you cannot trap immediately. But beautiful case, Niraf, thank you. Could you unshare your screen, and we'll ask Martin Samis to share his case with us.
Hello, it's fantastic to share with you the case from Europe, from Czech Republic. I hope you can see.
Yes, yes, we can.
You can see my pictures.
Is that your first slide? That's probably not your first slide.
No, it's not first.
Unless you operate first and then think about the case.
Okay, so it is large fusiform aneurysm ophthalmic, and it's unruptured. It's a man, good shape, and you can see that the P-com goes directly to posterior artery, so there is no communication with the basilar. There is no collateral. Here is a distal carotid, anterior, medial, and here is P-com and posterior circulation. So we did a balloon occlusion test, and there is no collateralization, so the balloon occlusion test was not tolerated. And my question is, if you prefer the endovascular technique in this in this fusiform ophthalmic, or you prefer surgical technica? If surgical, if you do prophylactic bypass for temporary clipping on the neck, and we can discuss it both techniques.
Martin, before they answer you, do you remember the details of the balloon test occlusion? Did the patient fail within a minute or 15 minutes into it, or you don't remember the details?
It was immediately. It was very, very quick. It
okay.
was. Mm-hmm.
And perhaps after our speaker's answer, we can, Bobby Stark, my endovascular partner, who's a co-director of this course, can tell us afterwards. So, and well, his thinking about endovascular options. But Mike, why don't you take that one first?
Yeah, I'm struggling a bit to really determine whether this is truly an ophthalmic or whether this is something else. Do you have, I guess this is all we have, but to me, this looks not just like an ophthalmic. Most ophthalmics, even large ones like this one, have necks that you can clip. And so I like to take these and aggressively expose them, clinoidectomy, ring dissection, get the neck out and give it a shot at clipping. And most of the time that's successful. This actually looks like not just your ophthalmic. This looks like the whole supraclinoid segment, that ophthalmic segment of the supraclinoid carotid artery is diseased. So I don't think you're gonna likely get away with the reconstruction. So that said, I think you know, your options boil down to a flow diversion strategy versus a bypass and trapping strategy. The thing that I don't like about the flow diversion is that you know, you've got a fetal PCA that tends to reduce the occlusion rate long term with flow diversion, as I understand it, and the open bypass and trapping would give you an opportunity to completely exclude that.
Fady, do you disagree?
No, I agree with Mike.
Okay. Bobby, are you
the vascular option? But I agree.
Bobby, are you? I cannot move the panel to see the faces of panelists. Bobby, are you with us?
Yeah, I think, you know, this is probably a case that we would consider for a bypass. I don't think there's a great endovascular option. I mean, if she had really tremendous or significant comorbidities, I'd have to look at the ICA again, but you could consider doing a stent from the distal ICA down, but then you'd need another stent that protects the fetal PCOM and then coil loosely around that. You need to preserve both of those branches. I think the hard part is, even if you're loosely coiling, you're not going to be able to get a down the barrel view to look down, straight down the barrel of the stent, but potentially flow diverting stent could keep that open. I would probably lean towards an open bypass.
Bobby, are you being kind of nice to the microsurgeons? Because I bet you this case presented in endovascular meetings, they would probably think we're criminal to even operate, you know, that para-ophthalmic or ophthalmic region aneurysms, there is no role for open surgery anymore. Are you like in middle of the road, or that's truly your thoughts about this? You know what I mean?
I don't think I'm middle of the road. I think when you have a fetal system, one flow diverting stent alone is probably not going to get the job done. So even if
okay, good to hear.
You know, I think you've got to preserve both branches. You know, we've shown other cases even recently where we've elected to do flow diverting with coils. I think those would be more interesting cases. This one, I don't see a great option.
Okay, thanks, Bobby. Martin, show us what you did.
So we decided for this strategy. We have no good proximal control, so we decided for prophylactic bypass, classical STA M4, and then prepare the carotid on the neck for proximal control, and tandem fenestrated clip for surgical clipping. So we did a clinoid resection, as Michael said, and then we prepared the STA bypass, is a STA donor flow measurement and TCD measurement, cut flow measurement, And then we prepare the prophylactic bypass for temporary clipping of the carotid in the neck. And this is shortly the prophylactic bypass for this temporary occlusion. And now bypass is prepared. And now we are here. There is a fusiform aneurysm. Here is A1, M1, and we put the clip now on the neck. So we have a temporary clip of the carotid on the neck, but we have a prophylactic bypass, so we have good flow because the balloon occlusion tests were immediately not tolerated. And now we use a fenestrated clip because it's the best solution for us, I think. And this is a first clip. Now we see the PCOM, so we use a second temporary clip, second fenestrated clip, and we solve the distal part of the aneurysm, and now we complete the exclusion of the aneurysm in the third fenestrated clip. So now is a no remnant, good flow in the posterior circulation, good flow in the MCA and the anterior, and we can see ICG. There is a beautiful chorioidal artery which is distally. So this is our final picture. So this is a prophylactic bypass. It's there in situ, and this is solution. 3 fenestrated clips, no remnant, and good vessels in the posterior and anterior circulation. So this is our surgery.
Martin, did you feel that the aneurysm wall that you're excluding from your clips? I mean, wasn't there still aneurysm? You're accepting that you're leaving some pathologic vessel wall, or did you feel on the other side at 180 degrees there was healthy non-aneurysmal vessel wall?
The vessel wall was good, was thick, and I was satisfied. And in our follow-up, there is no growing, and the situation is stable after 1 year.
Okay. Comments of the 2 speakers? No? Okay.
Yeah, nicely done.
Nice job, Martin.
Thank you, Martin.
You.
Thank you for staying late to be with us. Could you
fantastic to share with you.
Could you unshare your screen? So we'll ask Amal AbouHamden from Adelaide, Australia, to show us what case she has for us.
Thank you.
Thank you, Martin.
Thank you, Jacques.
Amal, unmute your speaker.
Good morning from Adelaide. I know it's good evening to you. Can you see my slides?
We can, yes. If you click on, playing the PowerPoint. Yeah. Thank you.
All right. Actually, it's been a wonderful morning for me here. Tour de force by everybody. Thank you for involving me. I might go straight to case 2, actually. This is a pediatric patient who is 10 years old, 10-year-old boy, no significant past medical history, fit and well, and presented with progressive 6-nerve palsy, so diplopia initially with some palsy, but then complete palsy over a sort of few months. This is his CT scan, and it shows this sort of dolichoectasia of ICA, but then turning into really a giant aneurysm, particularly in the cavernous portion. So never ruptured, just a 6-nerve palsy. What are the thoughts of our speakers and yourself, Jacques, in a pediatric patient?
Fady, why don't you start on this one?
Sure. So the complicating factor here is the pediatric age group. Plus, we don't know if there's an underlying collagen pathology related to that to be added. So one must suspect that this doesn't happen out of the blue so young. There has to be some underlying pathology related to that. So a sacrifice of this carotid, which could be a therapeutic option, would not be ideal because there's a high likelihood considering the young age, that de novo aneurysm will form somewhere else as a result of the increased flow demand. So one has to think of a deconstruction with some flow replacement, or I'd be curious to know what the endovascular option is. If there is no endovascular option, this would be an excellent case for performing the flow replacement algorithm, when one would go in, prepare the STA, since it's a young child, expose the M1 and the A1, check the flow as baseline, clip the carotid, and calculate the deficit. And if the MCA, if the STA is anywhere near replacing that, that would be enough. And with time, this STA will grow with the child and will continue to provide the replacement needed. So that would be how I would approach this case.
Fady, if the STA proves insufficient, radial artery, saphenous?
Yeah, so you escalate, you go to the next step, an interposition graft, you know, the John Little bypass, interposition graft with the radial artery, little short graft from the STA to stump to the MCA, or with a vein graft. We've published that a little while back. And again, a short graft rather than going to the neck to minimize the trauma for this child. My guess is that he will have enough collaterals from various sources to tolerate to be replaced adequately with either an STA, single or double barrel, or a short interposition graft.
Mike? Are you muted, Mike? Oh, can you guys?
Can you hear me now?
Now I can, yeah.
Yeah. I think this is probably a great one for an endovascular treatment. So I would give them the right of refusal on this one and see what they said. And if they didn't feel like it was a wise route to go down, I would not hesitate to do a bypass. Probably, I have a little bit less faith in the STA. I'd probably do a high flow interposition from the external.
Mike, I'm surprised you would, I mean, we'll ask Bobby what his opinion is in a second, but you're okay with multiple telescoping probably pipelines on a 10-year-old, committing him to antiplatelets for a while? I guess, what?
Well, for an aneurysm like this one that's purely cavernous, petrocavernous, yeah, I wouldn't have a problem with that.
Bobby, if you're not muted.
Yeah, I think it's a tough case, and I think you guys all brought up some good things. So I think in a child, I'm a little bit less excited about a bypass, but you're balancing that against, you know, our less than known history for stents and flow diverters and aspirin Plavix in children, although that's been done all the way down to infants as well. I don't love the idea of a balloon occlusion test and occluding this, for, as the other panelists said. I think that this is a reasonable case for flow diverting stents. I might try and get FDA exemption for the new Vantage stent, which we're starting in trials now, which is probably less thrombogenic. But I would probably use flow diverting stents and coils, because I think this is probably a pretty diseased vessel, and you need to make sure that you really reconstruct it and get good opposition. I assume we're talking about bypasses here, so we're about to show a failed endovascular strategy.
Well, Amal, before you tell us, I'm just reading so many Q&As being sent by the audience. I recognize Jorge Mura. Hello, Jorge, from Santiago, Chile, who's typing in IMAX to radial artery to M2. And then he's saying child radial artery is too short. But I guess what Fady was talking about is a short interposition to the STA stump. But okay, Amal, go ahead.
All right, so we did consider obviously those options. We did a balloon test occlusion with hypotension, which he passed. We did ask our endovascular colleagues about, you know, stenting options, flow diverting stent. They didn't think that was a good idea in a child this age for all the reasons you mentioned, and also just technically with those sort of sharp angles. of the carotid. So given all these circumstances, we elected to do a double-barreled Stamker and to occlude the carotid. But given that the main component that was enlarging was cavernous, so the occlusion started, we started the occlusion of the carotid distally from the cavernous and sort of worked backwards. So this was over 2 years ago now, and he's tolerated that extremely well. The sixth nerve palsy has completely recovered, and on CT perfusion, there's absolutely no concerns there. So back to Fady's point, just you know, good old simple STA, double-barreled STA, MCA bypass for this case did the trick.
Amal, did you do it very nice? Did you do it with flow guidance? Intra-op?
Yeah, that was before we bought Fady's probe. So I don't have the figures on that for you. We were reassured really by the balloon test occlusion findings with hypotension.
Great, very nice case. Comments from anybody before we move to Kiko?
Nicely done.
Great. Amal, thank you. We'll set you free to go start your OR list for today, correct? Your operative.
Thank you so much. Yes, cheers.
Okay. Thank you for coming so early. Kiko, can you share your slides, please? And unmute your microphone.
Oh, let me go to the first.
And thank you for staying up so late in Spain for us.
Thank you. Thank you. Thank you for the invitation. Now, I'm going to present you a case. Actually, we did this case today, and it seemed to me interesting. One of the reasons why Fady was here, because I've learned a lot from him of this kind of pathology. This case is a guy.
Click on the.
Okay, yeah. This is a 46-year-old male. He's an anesthesiologist of another hospital. And 10 years ago, in 2010, he was diagnosed by Bowhunter's syndrome. You know, a mechanical compression of the vertebral artery due to head rotation. I don't have all the pictures of that time, but apparently he suffered from vertigo, nystagmus, and ataxia when he rotated with head rotation to the left. At that time, he was managed conservative with anti-aggregation. But from time to time, he still suffered dizziness when he turned his head to the left. I don't have all the pictures of that time. I only have this because he was transferred to several hospitals. I only have the first one. And checking the vertebral injections of that time, nothing especially strange, but I don't have the dynamic studies with rotation of the head at that time. But what I have at that time is, I'm not talking about the origin because it's atypical. It's not from the subclavian. In the left is coming from the aortic arc. But look at this: the transition from V1 to V2 in the left, it's at the level of C3, and in the right is at the level of C4. And if you see here, there is a right angle. Might be some compression when you turn the head in the left. What is reasonable with the clinical picture? Apparently, in 2017, he suffered a stroke, and they diagnosed a left vertebral artery dissection. I don't have any images from that time. Apparently, he failed the VTO. He started to suffer dysarthria and dizziness when they occluded proximally this vertebral artery. So they put an stent. The patient was good for two years and a half, but starting that last December, he suffered since then 8 transient ischemic events in the last 6 months. 1 week ago, he suffered a sudden onset of dysarthria, vomiting, and dizziness. To sum it up, he suffered a dissection of B1, B2 segment of the left vertebral 2-3 years ago. They put a stent in other hospitals, no problems until December. One last stroke 1 week ago, and they transferred the patient this week to our hospital. On the MRI, this is our study now. We can tell now we have a left thalamic stroke and multiple cerebellar infarcts. And on the diffusion imaging, we could tell a huge, probably the largest, he had a superior cerebellar stroke. This is compatible with the embolic events. Now we see the stenting on the left side, and in the right side the variant is coming into the V2 segment in C3 in the left and in C4 in the right. And in this blow up image, we can tell here the transfer in contact with the stent, and something is happening with the stenting. Here we have the pin. And now our angio. The left ICA is fetal, the right is absolutely normal. You see the left in the neutral position, we could tell some kind of irregularity in the stent. The stent is damaged, you see, but nothing in the neutral position. But when we move to the right rotation, remember the first thing when he was diagnosed with the bow hunter syndrome was rotating to the left, not to the right. But now to the right, we can tell a kind of stenosis of the vertebra. With rotation to the left, it's more open, the vertebral, and we can see the damage to the stent. We can see now. And this is the neutral. The neutral is quite good, quite decent. But this patient, now we check, of course, the right, the other vertebral. It's very powerful, even more powerful. It's quite symmetric, but it's even larger, the right one. So I have my doubts because the bow hunter's syndrome is defined with the mechanical compression of the dominant vertebral artery, but here we have 2 vertebrals, so it's something strange to me. But now we have embolic events probably coming from the stent. So I have some questions for our professors. The first should be, what is this about? What would have been, if confirmed, the first treatment, the first treatment when they decided to do it conservative? Was a stent a good indication? And the next, what shall we do now?
Mike, you want to tackle some of this interesting case?
Yeah, I agree. It doesn't really add up. The fact that you've got symmetrical vertebral arteries and no confirmed occlusive process when the head turns, you're not replicating the symptoms on your study. It doesn't add up. I think the most impressive thing to me was what just living with that stent and his disease, what that did to the stent over time. So clearly, his head motion is traumatizing that upper vertebral artery on the left side, and that's probably the source of his disease. You know, the simple thing to do here, Kiko, is just sacrifice the artery, and you're done.
Yeah, but the patient failed to pass the BPO a couple of years ago, and so we were afraid even to try to perform a BPO less than a week after the embolic events from that vertebral. So that's what that was our concern. But we were, it was a couple of days ago, and we were tempted to occlude the artery. But the patient, he's a physician, he's an anesthesiologist, he reminded us, I failed the VTO, I remember that. And we have doubts because it's a symmetric case. It's not what we see in this case of in this kind of cases. But
it doesn't make sense to me that he would fail the BTO. This is an embolic disease, and he's showing embolic hits, not hemodynamic hits. And you know, a BTO shouldn't be failed. I might repeat that just to verify it.
Fady?
A very interesting case, Kiko. So first of all, this man has a congenital variation of the entry of the vertebral artery into the V2 segment. So that's predisposing him to compression and potential injury of the vertebral artery, actually both of them with head rotation. The stent, I think, made things worse because now you've introduced something more rigid that's as Mike mentioned, the stent is being impinged upon by the transverse process of C3 or C4, I can't recall where it was, on the left side, and that's eroding the stent. And I think that ultimately caused the injury to the vessel and the embolic problem. I think as well that this is an embolic problem. Just looking at the size of it, the right vertebral artery out of support, enough flow. Of course, what we do in this case is measure it with the NOVA. And if the flow is good through the right vertebral artery, we just sacrifice the left. Now, if on the other hand, one is not sure, or the flow is not good on the left, or in your case, sometimes you have to treat the patient and not the x-ray, and your hand is forced, what one can do. What can one do? Well, the thing to do here is pretty straightforward, is a bypass from the carotid artery to the vertebral at C1, C2, and then occlude the vertebral artery below the bypass to prevent any further embolic event. So choice number one would be sacrifice the left vertebral artery above. It has to be above where the stent is because collaterals will still recanalize it and you will still potentially throw an emboli. If the flow is good, if the flow is not good, sacrifice it after a distal bypass to the C1, C2 segment.
Kiko, tell us what you did because we're a little, well, we're quite a bit short on time, but it's so much.
And if surgery, I have some questions, but I'm going to answer them by myself.
Yes.
If surgery, what segment of the vertebral should be addressed? The surgical position and the donor. You know the B3 segment of the vertebral artery, it's from C2 to C1. It's very interesting because it's absolutely different from V2 because it's the position depends on the head rotation. So it's very, you can address this segment through an anterior approach or through a lateral approach. The difference is in either case, you have to rotate the head to the other side, but we get a more neutral position using the lateral position. That's what we did today. We used this lateral position, and in this way we achieve the neutral position with the, you know, the V3 has 3 segments, a vertical one, an horizontal one, and then an oblique one. Now we have the vertical is vertical, really vertical, not oblique, oblique parallel to the second. So this is here is the vertical from C2 to C1. I have uncovered the transfer orifice. This is the horizontal portion. And
Kiko, just for the audience, orient them where the arch of C1 used to be.
Yeah.
And the women transverse
the arch of C1 should be here. The posterior actually is here. But here there was an orifice with the transfer beyond the lateral mass of C1. So this is the vertical. This is the knee, and this is the horizontal portion of this V3 segment. Then you have the oblique one to the dura mater.
And
so we are from C2. This is the C2 posterior root. This is.
Show them the internal jugular vein, which you nicely moved forward. Yeah.
This is the internal jugular vein. I'm here. We have, and now I have here very close. This is another advantage of the lateral position because we take away the angle of the mandible and we mobilize the parotid, and we have the internal, the external, everything. But in this case, you see, I have my dots, as Fady said, because maybe as the bypass wasn't even needed. So you see in the ECG, we check first the flow, and now I put a clip on the vertical, and now I have distal flow coming from the other side. So maybe this patient tolerated the occlusion, but it's only 46, and this is very safe in this instance because I chose, I have three options: internal carotid, external carotid, or even I could reimplant this in the internal carotid, but I didn't want to move the artery because there was a perforator and I have my doubts coming to the spinal cord. So in this case, we performed the bypass using the proximal part of the occipital artery. It was very big here and we could use it. And this is the, no, this is the occipital, very close, everything here, maybe 1-2 centimeters for the ICA and the external from the vertebral in this position. I use the occipital and put the proximal clip. This is the ICG. There's still flow stuck in the internal jugular, and now we see the flow coming. And now we took the patient to the arteriography, and here you see the stem of the proximal occlusion. This is the occipital, and now this is the vertebral. So I think in this case, you have doubts even if the bypass is needed, but this bypass is really safe. And I talked to the patient yesterday because in this case, you don't put almost anything at risk. You have collateral flow during the bypass, and maybe if you see how well it's working, maybe it was needed. And this is the proximal occlusion. You see, I put a clip here. This is the vertebral, still open because it has a lot of muscular branches, and this is the distal injection, the ICA injection with this. Thank you. I don't know if you have any more comments or...
Speakers, any comment on this beautiful operation that may or may not have been necessary, but even though it's beautiful?
I agree. I think that's the indication is not clear, as you correctly pointed it out, Kiko. You were very straightforward about that, but it's beautifully done. It's a beautiful demonstration of this not very well known approach to the vertebral artery at C1, C2. The surgery was first performed by Dr. Andrew Carney here in Illinois in our hospital in the 70s, and he wrote a book even about that. Very useful surgery, as you said, very low risk surgery because it's an extracranial bypass. Nicely done.
Well, it's 7:25 p.m. We started with more than 600 participants. We're still up about 350. So maybe we can just spend 5 minutes answering some of there are like 40 questions, but may I suggest to the audience, I'm sorry, I don't want to keep you any longer or keep this panelist longer. I am sure any of the panelists, myself, the speakers, are happy to receive emails if you have questions that we are not answering today. Any of us could answer your questions. Just quick questions. Let me read a couple. Fady, I'll ask you this. Lifespan of bypasses. What can you tell the audience? Just a quick how long do bypasses last for? Does it matter the vessel, so forth? Oh, you unmute yourself.
So very different for ischemia and for aneurysms. The bypasses for aneurysms don't necessarily, the IC bypass last that long. It's probably because a type 1 problem. There's not as much flow needed. The bypass can give more than it takes and progressively an involute, which is fine. Bypass for ischemia, for carotid disease, it has very good longevity. For moya, about 2/3 of them involute over time.
Okay, maybe I'll ask Mike the next audience question. What are your tools to measure misery perfusion, Mike? What do you use at the BNI in assessing if somebody is in stage 2 hemodynamic insufficiency?
Yeah, we use perfusion scans, either CT or MRI, with and without Diamox challenge.
Okay. Fady, back to you. Somebody with bilateral atherosclerotic disease who's had a stroke in the right hemisphere and has bilateral decreased OEF by PET scan. And the Dr. Sarkar is asking the question, and he feels patient needs a bypass on both sides. Which side do you bypass first? The recently symptomatic side, or do you do like a prophylactic, well, not quite prophylactic, but you treat the OEF on the other side first, then do the symptomatic side?
In this case, the right side is the symptomatic one. I'll start for the right side. In atherosclerosis, there's a good chance that one bypass will revascularize both hemispheres. It's lower risk to revascularize the right side, and it's most recently symptomatic. So I'll go with the right side.
Okay. I'm sorry, I'm just sieving through many questions. Mike, back to you. Dr. Haridas is asking, wouldn't the anterior temporal artery donor be a problem on the dominant side? I mean, to use it or sacrifice it?
No. First of all, the anterotemporal artery is a side-to-side anastomosis. Typically, the way I perform it, you bring it in parallel to your M2, and you can bring those together side to side. That way, you don't sacrifice your anterotemporal artery. But even if you did, it's in a very anterior portion of the temporal lobe and would not be symptomatic if you lost it.
Thank you. I think I'm going to stop it here. There are people awake at 2:30 a.m., such as Dr. Kenan Al-Molki, who is very thankful for these, and I agree with him, beautiful presentations. Thank you all for staying 2.5 hours on this. Yes, all these sessions are being recorded. Somebody asked, they will be on our YouTube channel by next week through the link. Unless somebody has anything else to say, I will bid everybody good night or good morning.